Hello, listeners. Welcome to Views on Health. Back with us on the program tonight is Dr. Thushara Gunaratne, consultant vascular and transplant surgeon, National Hospital of Sri Lanka. Having spoken on an interesting topic last time around on the causality of non-healing wounds, tonight it's going to be carotid arterial disease. Interesting, doctor. A very unusual and new topic. I would rather you introduce this topic to our listeners. Over to you.
Thank you, Fatima, and thanks for having me back on the show. It's always a pleasure to join you on these discussions. What I thought was we'll talk about something a bit more technical. The viewers, like you said, are very conversant and familiar with health, and I think this is less spoken of, but equally very important. Before I talk about carotid disease, let me just tell you the background of why this comes. One very familiar term that I've heard is something called stroke. Stroke is basically more medical, but what happens is part of the brain has an issue in the blood supply. Either the vessel is blocked or there's a burst of a vessel and a part of the brain dies for some reason and causing effects. And this is seen very, very commonly. Sometimes people have a mini stroke where they have a small effect. Might notice the hand suddenly became numb, was holding the cup, but it suddenly gave away. But it didn't last for that long. The recovery is almost 100% and might have lasted for a little while, maybe a few minutes sometimes, maybe an hour. And that's called a transient ischemic attack or a mini stroke. Now, both these problems are related to my disease or my specialty in terms of carotid artery disease. Now, with that background of stroke, I'll tell you what the carotid arteries are. Now, the heart pumps blood to the entire body, and a vessel that supplies blood from the heart up to the brain are called the carotid arteries, and carotids are basically the neck vessels. So these two vessels, one on the right side, one on the left side, they traverse up from the heart through the neck and into your brain and supplies the blood supply to the brain. And the brain is also funnily manufactured thing, its own wonder and beauty. It's split in two parts. There's a right hemisphere and a left hemisphere. And the right carotid supplies the right hemisphere and the left carotid supplies the left hemisphere. But just to be noted that the right side of the brain controls the left part of the body and the left part of the brain controls the right part of the body. So this is what I'm going to talk to you about, and how we as vascular surgeons are involved in a surgical management of stroke.
Surgical management of stroke. How does that happen?
Right. So the stroke is because of a damaged part of the brain. And like I said, there are two ways this will happen. One is a vessel is blocked for whatever reason, and that's called an ischemic stroke. Sometimes it's because of a vessel bursting, popping, and that bleeds inside the brain. That's called a hemorrhagic stroke. If you look at all the strokes around, hemorrhagic actually is about 15 to 20%. The majority of strokes are because of an ischemic problem. That means there's something in the vessel that blocks them. Now, why it gets blocked is because it could be an inherent problem in the vessel in the brain, for example. But more often than not, what we see is it's a block that originates from somewhere else. It could be the heart, for example. The heart pumps the blood. If there's a clotting in the heart, it can go along the vessels and block the brain blood supply. About 20% of all these strokes, even 25%, but quarter of these strokes, actually happen because of a problem in the neck vessel. The carotid vessels is a very common place for cholesterol plaques to build up. If a patient has atherosclerosis, hypertension, diabetes, smoking, dyslipidemia, these patients are prone to have cholesterol build up in lots of places, including the neck vessel, the carotid. And about 20% of patients who have a stroke, the reason for the stroke is the block in the carotid vessels. As surgeons, we get involved in sorting that out.
Very interesting, doctor. Going on from there, so you have an involvement because there is a blocked artery. But the stroke has happened. So how do you come into it?
Good point. I think you directed me in the right path as to where I was going to head next. Now, the logical question is, why should you do something if you had a stroke? Now, majority of strokes are actually TIAs. Some of them are even not diagnosed; they're missed. Patient notices something, ignores it until it happens again. Because if the block in the neck, for example, hasn't been sorted out, it will keep on happening. If you look at all these patients with the big, massive stroke, you find a lot of patients who have had a huge ischemic stroke. They are bedbound, almost paralyzed, one part of the body not working. All of them have had these mini strokes before this happened. A lot of people with mini strokes, if you don't solve the problem, can end up having a major stroke. Now, the importance of diagnosing the cause and excluding carotid artery block is to prevent a major stroke from happening. So protocols in the Western world and even in Sri Lanka, even though it might not be enforced as rigidly as we would hope it would be, anybody with a mini stroke or a TIA needs to have done some very important tests, investigations within a matter of few days. That includes getting the heart assessed to make sure there are no clots in the heart, and getting a scan of the neck to make sure that the neck vessels aren't blocked. And if there are such blocks, and if they are deemed to be significant blocks in the neck, sorting that out surgically has a huge impact in preventing a major stroke in future.
Doctor, how does one diagnose a mini stroke? Now, you spoke a while ago of, say, for example, dropping a mug. And then you just don't take it seriously. That something has triggered within the body for that function to misfire, if I put it that way. You're holding a mug, you drop it, something's gone wrong. But then you think, I dropped it, okay, and then because you said that you recover almost immediately. Am I right? You said that. So therefore, how does one know this is a mini stroke? How does one sort of think, this happened to me today, I dropped this mug or something else that, if you can explain further, are there examples that can be considered going towards a mini stroke? How does one know this is it, and therefore I need to tell somebody if I'm alone, or I tell somebody who's in the house with me, or at work, wherever, and I need to see a doctor?
Absolutely. And I think that's the most difficult part. We not very much aware as to what these signs are, and we often ignore them. So when the brain supplies the body, it supplies one half of the body. It's the face, the upper limb and the lower limb. And what happens in mini stroke is a clot passes, but the clot dissolves because it's such a small clot. The bigger part of the clot is still left behind, waiting to get dislodged and blocked later on. But as the clot dissolves and the blood supply is replenished, the symptoms settle off. Now, those symptoms could be for a few minutes, a few hours, sometimes even a day. So what these symptoms are, it could be something like you suddenly find that you can't articulate your words, find the speech disturbed. A lot of times is somebody else noticing the mouth going to one side, a lot of deviation of the mouth. Patient is not very well for a short time. He will know that the hand is not working. Can't hold, it's numb anymore. I can't hold, I can't grip. The grip's coming, but it's coming very slowly. It's not what it was. Same for the leg. I could walk nicely, but I can't walk much now. It came back, but it's slightly heavy. I can feel that heaviness. I can feel the slight difference. And that's where the physician comes in. It's a physician who diagnoses a stroke. And it's really important that people are aware of what these signs are. And I think anybody who should, especially if they have parents or friends who are of the age where atherosclerosis kicks in. We all know what a heart attack is. We all know, we heard the story about heaviness of the chest and it going on the left side of the arm. This is the same thing, it's a brain attack. And we need to be aware of what these symptoms and signs are, especially if the patient is elderly, they have the risk factors like diabetes, hypertension, on cholesterol tablets. I think safe to Google stuff, see a lot of stuff on the internet as to what these signs are, but basically it tends to fall into a pattern of one side, is very important, face, upper limb, lower limb, arm and leg, and things like speech, difficulty in articulating, face drooping, hands are weak, hands are heavy, the grip strength is lost, same for the leg. These are signs saying that you have had a problem. Go and see a physician, get it diagnosed. If and when they do diagnose a TIA or a stroke, it's really important that those tests that I talked to you about are done and assessed.
So all these signs have got to be taken note of.
Absolutely.
And not neglected, actually.
Absolutely. I think it's far better to err on a side of caution and see somebody rather than ignoring it and being complacent about it. Because the reality is, if it is indeed a TIA or a mini stroke, there's a considerable chance that you could have a major stroke in the near future. And the important is that there are so many things we can do to prevent it. Because once you have a stroke, you are having so many complications. You're on a bed, sometimes you might be paralyzed, sometimes you might die, need support to eat, need support to get out of the bed, you can't use your own bathroom. So many things are affected, your family is affected. And prevention of the stroke is a really crucial thing. And that is where we as a vascular surgeon get involved. Primarily if the stroke is due to a carotid artery disease.
Good to hear, doctor, that you can preempt a major stroke if you know the signs are there of mini stroke or strokes for that matter, and you can address the problem, the health issue at that point, and prevent a major stroke. Would you say that's right?
Absolutely.
So that's a big relief. Yep. And I think something that our listeners should take note of.
Absolutely.
Because why go through all the problems and then suffer a stroke when you can preempt it?
Exactly. I think the key thing is to consult somebody if you do find these symptoms. And I think it's really important you ask the questions as to whether these tests have been done to look for a cause. Diagnosing is important. Looking for a potentially reversible cause is equally important. Unfortunately, in the state sector, for example, where we're relying on government-funded investigations, the tests are done so far away, the dates are so far away from the index event, that sometimes by the time the patient gets all these tests done, they've already had another stroke, for example. In the UK, for example, it's mandatory that the carotid vessels are assessed within 24 to 36 hours. It's really important. And in those kind of places, treating a disease of the carotid artery, if it was important, should be done within 7 to 10 days. And that is what's really important. That's what I want to drive the message, that patients seeking attention early and getting these tests done early is very important to make sure a stroke is prevented.
Doctor, you spoke of a big clot that is able to get dislodged and then cause massive damage. Now, if you perform that surgery, can that be taken care of? Can that be addressed?
Right. So this is where we get in. So it's normally the physician who will do this initial part, managing the stroke. Sometimes they use various clot-busting drugs, for example, and they will try and sort that out at that moment. They will arrange what's called an ultrasound scan or a duplex scan of the neck vessels of the carotid artery, and they will look at how much of plaque buildup is there. If there is significant amount of plaque buildup and the vessel is therefore obstructed or compromised, then they refer to us, and we get involved in trying to clear that clot out before the next clot dislodges. So it's a surgical procedure, and it is a complex procedure, one of the complex stuff we do, of the vascular surgeries we do. It's a very delicate area, and I talk about some complications that will affect the way you look at this surgery. But the idea behind it is to remove that clot, that plaque that has ruptured, and prevent it from happening again. And if you do it early enough on the right patient, you can prevent a stroke from happening.
So would you do some sort of test to locate the point where the clot is?
Yes. And a first line investigation, that is where these investigations come in, is the carotid duplex I spoke about. It's a ultrasound scan, a gel scan, very straightforward, painless procedure. It takes 5 minutes to do by the right person, and they will look to see what the block is. Sometimes that might not be enough, and they will do more complex tests like a CT scan or a MRI scan, which will give us a lot of information that we require. But the first line is the conventional gel-based ultrasound scan of the neck, and that will tell us where the block is, what the other side is like, and to tell us what chances are that this is the primary problem for that stroke that you had or the TIA you had.
How common is this?
Unfortunately, we don't know, because most often in Sri Lanka it's underdiagnosed. Hardly ever do we get patients sent early. When you do get a patient, it's too late. But if you look at the West, where it's very common, I wouldn't want to give a number in Sri Lanka, but patients have heart attacks. The risk of a brain attack because of this is not too dissimilar. We in our unit, because we get a lot of referrals, we do see a lot, and in terms of the burden of surgeries we do, it's about 20 to 30 such surgeries for a year in our unit alone. And I think in Sri Lanka, amongst all vascular surgeons, about 100 to 150 of these are done. Mind you, not everybody with a stroke will have a disease. About 20%, like I said, of patients who have a stroke, this is the cause. And not all of them are perhaps fit for a surgery as well.
Thank you, doctor. So interesting. I'm just really fascinated. I'm just imagining the process that a patient is put through, and you're dealing with it as the surgeon, and getting to the crux of the problem to address it, and then, obviously the patient is going to have a lot of relief thereafter. Now, if the other side, if the stroke has happened, do you have a role to play?
If a stroke is not major, for example, a minor strokes, not a TIA, there is definite disability.
Something in between?
Something in between. If a patient is bedbound, where the CT scan has shown that the brain function is not useful anyway, there is not a lot to achieve. The reason is this: the surgery involves cutting into the carotid artery. And this is where the block is. This is where a clot is. We need to get to that point. We need to control the artery. We need to open it. We need to clear the entire stuff out, close it back, and let the blood flow. Now, it's working with a dangerous vessel in a dangerous place. And the problem is, there is a risk that until we do clear all of this, small clots can still pass through. Now, the idea behind this surgery, the carotid endarterectomy, is to prevent a stroke. But the process itself has a risk of stroke involved. Now, the risk of having a stroke because of the surgery is about 1 to 2%. So, unfortunately, although we do aim to prevent a stroke from happening, from about 100 patients, 1 or 2 might get a major stroke because of the surgery itself. So that's a catch behind doing this surgery. But the other end of the coin is that for some people, and we do a risk stratification, if you don't do the surgery, the risk of having a stroke is about 10 to 20%. So it's to find the right patient for whom the risk and the benefit balances out, for whom the patient is fit enough, for whom the patient we feel would benefit from taking a lesser risk, but preventing a risk of having a major stroke in future. And that is the difficulty in this process, and that is where we get involved as a vascular surgeon.
What's the age or the general age where a person can get a stroke?
It tends to be the middle ages to late ages. So looking at about a person who's normally over 55 years, most commonly 60s. It can go up to 70s as well, 75s. Beyond 80s, it happens, but sometimes it's the patient itself is not fit enough. So we might manage the patient medically. So anybody with a stroke, even if the cause is the carotid vessels, they need to be on the right drugs. So whether surgery happens or not, the medical management will take place. The lifestyle changes will take place. Making sure the risks are controlled will take place. So getting the sugar under control, hypertension under control, cholesterol levels under control, stop smoking, eating well, lifestyle, all very important. They normally will be on a lipid lowering drug like atorvastatin. They will be on an antiplatelet drug like aspirin or clopidogrel. So those things are must and essential. When we do the scans, we'll see how much of block is there. If there's a block but it's not great, let's say it's about 50% of the artery is blocked, we actually won't intervene. If the block is more than 50%, then the risk of having a stroke becomes higher and higher. For somebody with, for example, 90% block, the risk is huge. And not doing means you're taking a huge gamble in having a major stroke. So it's also finding that right balance, looking at all those parameters, seeing how fit the patient is to decide on whether what is right for that patient.
Gender?
It's common in males and females, both. Unfortunately, females fare worse in terms of stroke and surgery. Perhaps it could be the smaller vessels they have in general to a male. In general, women have poor outcomes in vascular surgery, in arterial surgery. That's across the global statistics, but it's common among both. With age, women do have a protective effect, and males are higher in terms of their incidence.
Very intricate process.
It is. It's a very, very delicate surgery. There are so many important structures in the neck. There are a lot of vessels there, a lot of nerves there. The artery is very delicate. It's a very fine surgery. We need to get the artery, control the artery without dislodging these clots, which are hanging by a thread as if it were. So it's a very delicate surgery. It requires very lot of precision, and not many people do it. It's a vascular specialty field, basically. And the idea is to control the artery without dislodging the block. Then we open into the artery, clear it out, and we close it back. Once that is done, your risk of having a stroke is almost negligible. So you come from about 20% risk of stroke over the next 3 to 6 months to about 0, and you're okay for life afterwards. You need to be on the right drugs though, but the risk of stroke is therefore nullified.
That's tremendous. Just a question, doctor. I don't know how fair this question is. This type of surgery, can it affect any other part of the body, or can it can have any sort of anything detrimental towards one's health? A stroke you take care of, obviously. So therefore, it's wonderful, good news. But is there a chance that any other complication can arise, or any other part of the body can be affected? I'm just asking.
Sure, it's fine. I'm not sure whether I misspoke myself. And let me just clarify if it is so, the viewers might have misunderstood me. Once a patient has a stroke, the surgery we do can't change it. So let's say a patient has a disability, the arm is weak, for example. This surgery can't make it better. Getting better requires physiotherapy and all the right medicine. So what we do in terms of the surgery is to prevent the next stroke from happening. But like I said, it's a very delicate area, delicate structures around it. So there are risks involved. The biggest being a risk of stroke with the surgery, and that's about 1 to 2%. The other things are less of an issue. Bleeding, hematomas can happen. It is a cosmetic procedure in the neck. There are newer things called stents that can be used, but these are reserved for people who are not fit for a surgery. So on balance, surgery would be the preferred option if the patient warrants it based on the assessment that is done.
Stent as in like in heart surgery?
Absolutely. But the stent has a lot of other issues as well, and therefore in evidence globally, endarterectomy or the surgery is the preferred option if the patient is fit enough for it.
Dr. Time has caught up with us, unfortunately. Could you just recap how one can identify a mini stroke?
Sure, thanks. So I think awareness among the public is a crucial thing. A stroke is because of a block or a burst of a vessel in the brain, causing a temporary or a permanent damage to the brain cells. And this can be affecting the face, arm, and the legs on one side normally. It could be short time, like a mini stroke for lasting less than 24 hours, or it could be a big stroke that is for a longer time. Regardless, it is very important that a person goes and sees a physician, and it's very important that the physician does some important tests, including assessing the neck vessels. 20% of all strokes are due to a block in the carotid arteries or the neck vessels. And in some people, it is really important that that block is cleared to prevent a future major disabling stroke. And that is where we get in.
Thank you, Doctor. On that note of advice, we end this very interesting discussion on carotid arterial disease. To you, Dr. Thushara Gunaratne, Consultant Vascular and Transplant Surgeon of the National Hospital of Sri Lanka, our grateful thanks.
Thank you,
from
Fatma.
SLBC. Thank you so much, Doctor. It's been a
you.
great pleasure having you with us on the program and listening to you explaining about strokes, mini strokes, and where you as a vascular surgeon come in to deal with the carotid artery. Thank you, Doctor. Thanks also to Malinta Deshapriya for technical assistance. I'm Fatima Razi Kadi saying good night and looking forward to your company next Monday, same time on Views on Health.